Okay, when you want, you can start, Bob.
Okay, well, good afternoon to all of you attendees who are joining us directly, and we are a select group this afternoon. I note we currently have 14 of you, so very nice to have you on board. So this will be the final session of our spring series. We have to decide what is going to happen in the future. So if any of you who are with us today have ideas of things you would like us to discuss, please let us know. We're joined today for discussion by Diane and by Norman from San Francisco, by Adrian from Birmingham. But we're going to start off. Sasha is going to play through for us the recording, and Diane's videos today are quite spectacular. So please have all your questions ready. We're ready to respond to any thoughts you may have. So Sasha, get us going with overriding arterial valves. It's not working at the moment. Atrioventricular valves. And we emphasize that not only do the atrioventricular valves have an orifice, but they also have tension apparatus. And that is important because the tension apparatus is then able to straddle, whereas the orifice overrides the crest of the ventricular septum. So today, when we're discussing arterial valves, we have to remember that they lack a tension apparatus. And so this means the arterial valves cannot straddle, but they can override. And we see that when there is an outlet defect and when the orifice, the arterial valve is, as with the atrioventricular valve, overriding the crest of the muscular ventricular septum. The key point for today's discussion is that it will be the extent of the override that will determine the specific ventriculo-arterial connection. And that's what we're going to be concentrating on for the remainder of the session. But we should also remember, although we're not going to show you this, the common arterial valve usually overrides. But on occasion, the common arterial trunk itself, rather than overriding, can arise exclusively from the morphologically right, or sometimes exclusively from the morphologically left ventricle. And that is then akin to the situation we see and we describe as double outlet right or double outlet left ventricle. And so we have to recognize that there is a spectrum, depending on the extent of overriding, between exclusive origin as opposed to override itself. And today we are going to be discussing those spectrums not in the setting of the common arterial trunk, but in the setting of the aortic valve, the pulmonary valve, or, on occasion, both the arterial valves. So what we are going to be discussing today is a tale of 4 spectrums. And we're going to start off with the commonest of those spectrums, and that is the overriding aortic valve in the setting of Tetralogy of Fallot. We'll then move on, and we'll discuss the situation when the aortic valve overrides without there being any pulmonary stenosis. And that is what we call the Eisenmenger defect. Then we're going to change our attention, and we're going to look at the overriding pulmonary valve. And we can call that spectrum the Taussig-Bing malformation. And then we're going to finish up when both arterial valves are overriding, and nowadays, increasingly, that arrangement is called double outlet, both ventricles. So let's start off with looking at a lesion that we remember in the name of Arthur-Louis-Étienne Fallot. I hope that by now you all know the phenotypic feature of the tetralogy described by Fallot and now named for him is the squeeze we see at the mouth of the subpulmonary infundibulum. But we should also remember that Fallot himself, when making his original description, noted that sometimes, despite the presence of that squeeze at the mouth of the infundibulum, the aortic root can arise exclusively from the right ventricle, what nowadays we're going to call double outlet right ventricle with tetralogy of Fallot. So let's remind ourselves of the phenotypic feature. You're going to see this very shortly in the exquisite data set, the exquisite videos that Diane has prepared for today's session. But here's the picture I like to show, illustrating the phenotypic feature of tetralogy of Fallot. So there you see the malaligned muscular outlet septum. And you see it is closely aligned with the parietal wall of the right ventricle, and those septoparietal trabeculations reinforcing the wall of the right ventricle are themselves hypertrophied. And this is producing that squeeze at the mouth of the infundibulum. But there is also, of course, overriding of the aortic root. And it's that override on which we want to concentrate today. And nowadays you can see it in your computed tomographic images. Now this is an exquisite computed tomographic image made quite some time ago, shared with me by my good friend and colleague, Tony Novarchek, from the University of South Carolina. And what Tony has shown in this two-dimensional cut is the cone of space that exists beneath the overriding aortic root. This, of course, is a complex three-dimensional space, but as you see here, we can represent it in these two dimensions. And what I want you to concentrate on through the rest of the session is the communications between this cone of space and the right as opposed to the left ventricle. So there you see a double-headed arrow that I've shown in green. And this is the subaortic left ventricular communication. And hopefully it will become very obvious to you soon why I've shown this double-headed arrow in green. Because then on the other side, we have a double-headed arrow that I've shown in red. And you'll immediately appreciate that this is the subaortic right ventricular communication. Now, why the difference in colors? The difference is because irrespective of the extent of override, it is that subaortic left ventricular communication that will function as the outflow tract of the left ventricle. So during any surgical procedure, it would be a disaster to close that subaortic left ventricular communication. It is the subaortic right ventricular communication that will be closed to restore septal integrity, and that is why I marked that one in red. So let's now look these not in my pictures, but in the videos that Diane has prepared. And she's going to start off by showing you the situation in Tetralogy of Fallot.
This specimen has Tetralogy of Fallot, and you can already appreciate the smaller caliber of the pulmonary trunk relative to the aorta. The arterial trunks are relatively normally related, with the aorta slightly anterior and to the right of its usual position. You can already appreciate the right ventricular hypertrophy, And you'll see my finger in the aortic root, showing us that the majority of this aortic root is committed to the left ventricle. If we look at the borders of the ventricular septal defect from the right ventricle, I should say, you can see that this is the ventriculoinfundibular fold, which will be that portion of muscle that is supporting the aortic valvar component that is overriding the interventricular septum or within the roof of the right ventricle. The ventriculoinfundibular fold is also that muscle bundle that separates the atrioventricular from the arterial valve. The posterior inferior border shows us that this is a perimembranous ventricular septal defect with fibrous continuity between the tricuspid and mitral valves. The defect extends between the limbs of the septomarginal trabeculation, making it an outlet defect, and this is the septomarginal trabeculation. You can see the medial papillary muscle arising from the caudal limb, which does not reach the ventriculoinfundibular fold. The remaining border is this prominent right ventricular structure, or our outlet septum, which is deviated in anterior superior position, causing this subpulmonary stenosis. Looking at the specimen from the left side and tilting it upwards, you can now see that the majority of this aortic root is committed to the left ventricle. Again, if I place my finger in the defect, we can assess the borders from the left side, so that here is that ventriculoinfundibular fold supporting this component of the aortic valve that is overriding the interventricular septum or partially or committed to the right ventricle. Here you can see the outlet where the ventriculoinfundibular fold joins the outlet septum, and this is the component that extends between the limbs of the septomarginal trabeculation, and our fibrous continuity between the tricuspid and mitral valves, making this a perimembranous ventricular septal defect. So that the majority of the aorta, in this case with Tetralogy of Fallot, is committed to the left ventricle. If we look at a specimen that has the tetralogy variant of double outlet right ventricle, and I tilt the specimen upwards, you can see that there is very little of the aortic valve that is overriding the septum and committed to the left ventricle, so that the majority of this aortic root arises from the right ventricular chamber. If we look at the borders of the defect again, you can see this ventriculoinfundibular fold, which is that muscle that separates the aortic valve from the tricuspid valve. And you can see that this is quite a bit smaller of a muscle component than in the last heart, so that there is a degree of variability in these specimens. Along the posterior inferior border, there is fibrous continuity between the tricuspid and mitral valves, rendering this a perimembranous defect that extends into the outlet component of the right ventricle between the limbs of the septomarginal trabeculation. And this is our prominent right ventricular structure, or the outlet septum, that is deviated in anterior superior position, causing this significant subpulmonary stenosis. I will also point out that in some specimens, you can have a complete subaortic infundibulum along with a complete subpulmonary infundibulum. This specimen does not have that, but I can show you that it has a significantly increased area of muscular support in this area, and with the ventriculoinfundibular fold also supporting this leaflet and this area between the aorta and mitral valve. That fibrous continuity is quite shallow in this particular specimen. So the way the specimen was sectioned, it's not opened into the left ventricular outflow tract, but we can still view the left ventricular outflow tract beneath the anterior or aortic leaflet of the mitral valve. And you can see this area is what the portion of the defect that extends between the limbs of the septomarginal trabeculation, and that the aorta is mostly committed to the right ventricle, so that this area remains the left ventricular outflow tract. So that if this specimen is repaired, it will be the aorta to right ventricular communication that will need to be patched to place the aorta back into the left ventricle. If we look at a 4-chamber cut of a specimen that does have Tetralogy of Fallot, we can see the tip of the right atrial appendage, the left atrium, right ventricle, left ventricle, and here's the interventricular septum with the aortic root overriding the interventricular septum and slightly more committed to the left ventricle than the right. So if we look at the area where it will be repaired, as Professor Anderson showed you with the CT rendering, you can see that the patch from this ventricular infundibular fold to the crest of the septum will close this aorta to right ventricular communication and place the aorta back into communication with the left ventricle. If we push this septum to illustrate how a double outlet right ventricle might look, we can see that the aorta is now more committed to the right ventricle, with this left-sided component remaining as the left ventricular outflow tract. And that when this area is patched, the aorta will need to be tunneled into the left ventricle with a patch across the aorta to right ventricular communication, so that this patch is in a much more perpendicular position than the patch in hearts with Tetralogy of Fallot, which is in a much more parallel or relatively parallel position with the crest of the interventricular septum.
So now you've seen those spaces, the subaortic right, the subaortic left ventricular communication. And we have a potential paradox in the way we name these defects. Because I hope you will agree that when you ask the surgeon to correct Tetralogy of Fallot, you hope the surgeon is going to close the ventricular septal defect. Here is the problem. Because in many centers, probably including your own, when you diagnose a patient as having double outlet right ventricle, nowadays it's that subaortic left ventricular communication that is nominated as the ventricular septal defect. And I hope you will agree that it would be a disaster, as we've already discussed, for the surgeon to try to close that subaortic left ventricular communication. So let's go back to those hearts you've seen already, and let's ask Diane to discuss this again in terms of the paradox we have in naming these defects.
The area considered as the ventricular septal defect is this subaortic to right ventricular communication. A patch will be placed in this area to restore septal integrity. So if I put my finger in there, you can see how the ventricular septal defect would be patched, putting the aorta back into total communication with the left ventricle. If we look at the specimen that has the tetralogy variant of double outlet right ventricle, we know that the majority of this aorta is committed to the right ventricle. When we look at the defect from the left side, you can see the area that is extending between the limbs of the septomarginal trabeculation, and that the majority of this aorta is committed to the right ventricle or arises from the right ventricle. And although many would describe the subaortic left ventricular communication as the ventricular septal defect, this area cannot be closed because it remains the outflow for the left ventricle. And we looked at the borders of this ventricular septal defect previously. And so if I replace a chunk of this heart that was removed from the outflow tract, you can now clearly see those borders that will need to be closed to tunnel the aorta back into communication with the left ventricle to ensure septal integrity. So that if this area is not the ventricular septal defect, it does not currently have a name.
So, we do have a problem. But there is another thing we have to take into consideration, because perhaps those who argue in favor of retaining the name ventricular septal defect when there is double outlet right ventricle will argue that you can only have double outlet right ventricle when there are bilateral conuses. And that means Tetralogy of Fallot cannot coexist with double outlet right ventricle. But we can immediately show you that that is not the case, because on occasion, patients with bond-or Tetralogy of Fallot can have bilateral conuses. It is rare, but it does exist. And here is an example from my own collection. It's comparable to the one I showed you in the garden variety of Tetralogy of Fallot. And there you see the squeeze at the mouth of the subpulmonary vestibulum. So there is no question but this heart is showing us Tetralogy of Fallot. And there's also overriding of the aortic root. But look very carefully, and you see there is a completely muscular subaortic infundibulum. So nowadays, I hope you will agree that we do not diagnose double outlet right ventricle on the basis of there being bilateral infundibulums or conuses. In fact, I hope you will all agree with me that double outlet right ventricle is a ventriculo-arterial connection, one form of ventriculo-arterial connection. And within that setting, infundibular morphology is an independent feature. So there's no question but that Tetralogy of Fallot can coexist with double outlet right ventricle. So how do we make the diagnosis? So let's now go back and let's ask Diane to show us the hearts yet again and take us into the diagnostic procedure.
Using the same specimen, again with Tetralogy of Fallot, we can see how the surgeon will place the patch to restore septal integrity. So we know that the sutures can safely be placed along the ventriculo-infundibular fold, along the outlet septum, and along the crest of the ventricular septum. The dangerous area is along this posterior inferior border where we have perimembranous extension of the defect. And if we look at the location of the apex of the triangle of Kalk, you can see where the atrioventricular conduction axis will be located, and that the right bundle branch will run along this area and will emerge relative to the medial papillary muscle and extend along the septomarginal trabeculation. So if I put my finger in here, we can kind of illustrate where the patch will be placed. And you can see that the patch will be in a much more parallel position relative to the interventricular septum to restore septal integrity in Tetralogy of Fallot. If we look at, again, the same specimen that had the tetralogy variant of double outlet right ventricle, and I replace the piece of aortic root here to show how the patch will be placed and the aorta will be tunneled into the left ventricle to restore septal integrity. So you can see where the borders of that defect would be patched to tunnel the aorta back into communication with the left ventricle. And if I tilt it to the side, you can see how that patch will be in a much more perpendicular plane with the crest of the interventricular septum than it was in the heart with Tetralogy of Fallot and concordant ventriculo-arterial connections. Again, this area along the posterior inferior border will be the area where the surgeon has to carefully place the sutures to avoid any damage to the conduction tissue.
So what we can now do on the basis of the extent of override is give a pragmatic definition for what is double outlet right ventricle. And it all depends on what you, as the diagnostician, are going to ask the surgeon to do. Because you will, I hope now you will agree that if you say to the surgeon, please close the ventricular septal defect, that means that initially the patient, in the setting of the overriding arterial valve, must have had concordant ventricular arterial connections. But if in contrast you say to the surgeon, what I want you to do now is to go into the operating room and I want you to tunnel that subaortic left ventricular communication so that it communicates with the aortic root. In that setting, you will have made the decision that the patient initially had double outlet ventricular arterial connection. So it's as easy as that. So let's now move on and let's look at the next of our four spectrums, the Eisenmenger defect. What is the Eisenmenger defect? Well, it's the situation in which we still have malalignment of the outlet septum. We still have a defect that is subaortic, but the malalignment of the outlet septum is insufficient to produce subpulmonary obstruction. And these are the defects that Victor Eisenmenger himself described at the end of the 19th century. So the Eisenmenger defect is a malalignment defect, a malalignment outlet defect, but without there being any subpulmonary obstruction. Again, we're going to have a spectrum. And that spectrum is going to be between concordant and double outlet ventricular arterial connections. So let me start off by showing you something at the midpoint of that spectrum. So here is my picture of the Eisenmenger defect. You see that the outlet septum is still malaligned. There are hypertrophied septoparietal trabeculations, but this time those hypertrophied septoparietal trabeculations do not obscure the subpulmonary outlet. But there is overriding of the aortic root. So this is the Eisenmenger lesion. So let's now ask Diane to take us through the spectrum as she did with tetralogy, but this time showing us an Eisenmenger defect.
We're looking at this heart in attitudinally appropriate fashion, and you can see that the arterial trunks are normally related so that there are concordant ventricular arterial connections. And you'll note that there was a pulmonary artery band in this case. If I tilt the windowed right ventricle upwards, you can see the tricuspid valve in the inlet, the pulmonary valve in the outlet, and there is a prominent outlet septum, but no pulmonary stenosis. A perimembranous ventricular septal defect is also present, and there is slight override of the aorta. The surgeon in this case will place their patch in this area to restore septal integrity and totally put the aorta back into communication with the left ventricle. If we look at a similar specimen, but one that has a double outlet from the right ventricle, looking at it in attitudinally appropriate fashion, again, you'll note that the pulmonary trunk and the aorta are side by side with one another, with the aorta anterior and rightward of its normal position. Also, they are both of similar caliber. Looking at the right ventricle, you can see the tricuspid valve in the inlet component and both of the outlets arising from the right ventricle with this prominent outlet septum and no pulmonary stenosis. So when the surgeon repairs this double outlet right ventricle, the patch will be placed in this area in order to tunnel the aortic root back into communication with the left ventricle, so that the area that is closed or patched is the subaortic right ventricular communication.
So now we've finished with the spectrums in which it was the aortic root that is overriding. Now we need to turn our attention to the Taussig-Bing malformation. So what is the Taussig-Bing malformation? It is the spectrum of override we see when it is the pulmonary trunk that is overriding that outlet defect. And the spectrum now will move from there being discordant ventricular arterial connections, transposition if you will, to double outlet with a subpulmonary interventricular communication. So let's now ask Diane to show us a video illustrating the spectrum we see in the setting of the Taussig-Bing malformation.
We're looking at this specimen in attitudinally appropriate fashion, and you can see the aorta arising anterior and slightly leftward of the pulmonary trunk from the ventricular mass. There are discordant ventriculo-arterial connections, and here you can confirm that by seeing the right coronary artery and the left coronary orifice arising from the aortic root, and the aorta arising from the hypertrophied morphologically right ventricle. If I tilt the specimen upwards, you can see the pulmonary valve here and appreciate that there is some slight override of the pulmonary valve, but that it is committed in its greater portion to the left ventricle, again confirming discordant ventriculo-arterial connections. There is a muscular outlet ventricular septal defect, so the defect extends between the limbs of the septomarginal trabeculation. The caudal limb extends to reach the ventriculoinfundibular fold. When the surgeon is going to repair this ventricular septal defect, a patch will be placed on the right ventricular aspect, and this posterior inferior muscular bar will be protective of the conduction tissue. Once the septal integrity is restored by a patch, then the surgeon can do an arterial switch to correct the circulation. Looking at the Taussig-Bing, or the so-called Taussig-Bing spectrum of double outlet right ventricle, we can see the right ventricle has been windowed. Here is the tricuspid valve in the inlet, and this ventricle again is hypertrophied. Looking at the arterial trunks in attitudinally appropriate fashion, the aortic valve is arising, or the aorta itself is arising anterior and rightward of the pulmonary trunk. The aortic valve is supported by a complete muscular infundibulum, and we can see that the pulmonary trunk is committed in its greater portion to the right ventricle. The left ventricular outflow tract exists where my probe is, and there is a subpulmonary interventricular communication. When we look at the left ventricular outflow tract, it is this area here that many refer to as the ventricular septal defect, and this cannot be patched because it would cut off the left ventricular outflow tract from the pulmonary trunk. This subpulmonary interventricular communication has to be tunneled into the left ventricle so that a patch will be placed in this area to tunnel the right ventricular to pulmonary trunk communication back into communication with the left ventricle. This defect is an outlet defect and currently does not really have a name. When the defects are outlet defects, they extend between the limbs of the septomarginal trabeculation. And the interesting thing about the so-called Taussig-Bing malformation is that the caudal limb of the septomarginal trabeculation now is in direct attachment or communication with the outlet septum. This specimen also has a subpulmonary muscular infundibulum, which separates the mitral valve from the pulmonary valve. It is a thin muscular bar, but still separates the pulmonary valve from the mitral valve. And I should mention that when this interventricular communication is tunneled, the caudal limb of the septomarginal trabeculation will be protective of the conduction tissue, just as it was in the specimen with the discordant ventriculo-arterial connections. I don't have a specimen with a perimembranous ventricular septal defect and the so-called Taussig-Bing malformation, but this fetal heart will serve to demonstrate the areas that are the danger zone for the surgeon when they are tunneling the pulmonary to right ventricular communication back into the left ventricle. Here again, you can see the aorta side by side and to the right of the pulmonary trunk, and there is a subpulmonary interventricular communication. Here's the tricuspid valve, and here is the mitral valve, which in this heart is in fibrous continuity with the pulmonary valve. And in this area, if this thin muscular bar was not present, the tricuspid valve and the mitral valve would be in fibrous continuity with one another. And the surgeon would have to be very careful along this posterior inferior border when tunneling the right ventricular to pulmonary communication back into the left ventricle. And once that was completed, then an arterial switch could be performed to restore the circulation.
So now we've been through 3 of our 4 spectrums. So what we need to finish with is looking at the spectrum of double outlet, both ventricles. And here we have to come back to the outlet septum, and we have to think of the way that it is attached, be it muscular or fibrous, to the subarterial outflow tracts. Because it is the attachment of the outlet septum that determines the way in which interventricular communication communicates with the arterial roots. So let's start off by looking at the first of our spectrums, namely overriding of the aortic root. So here I'm showing you an example of double outlet right ventricle with a subaortic defect. There you see the interventricular communication, and by now you know that that is the subaortic left ventricular communication. It can never be closed. There now you see the muscular outlet septum. And you will note that in this particular heart, it is attached to the cranial limb of the septomarginal trabeculation. And that means that the defect is opening to the right ventricle between the limbs of the septomarginal trabeculation. But because the outlet septum is attached to the cranial limb, the interventricular defect is now being directed into the aorta. And note that in this particular heart, there is fibrous continuity between the leaflets of the aortic and mitral valves. We do not need to have bilateral tonuses to make the diagnosis of double outlet. So here we have double outlet with a subaortic defect. It is the end of our first 2 spectrums of malformation. This is what we saw at the end of the spectrum of the Taussig-Bing malformation, double outlet with a subpulmonary defect. There again, very nicely, you see the muscular outlet septum, but this time it is attached to the caudal limb, the septomarginal trabeculation. And that now means that the interventricular communication is directed not into aorta, but into the pulmonary trunk. In this instance, in the setting of bilateral infundibulums. So that leads us on to the final of our spectrums, the spectrum of double outlet, both ventricles, because the key to this spectrum is that the outlet septum is attached neither to the cranial nor to the caudal limb of the septomarginal trabeculation. And here is a lovely example of what we might now call double outlet, both ventricles. There is the interventricular communication. Still, it is opening into the right ventricle between the limbs of the septomarginal trabeculation. In this instance, the outlet septum itself is fibrous, but you will note that it is attached neither to the cranial nor to the caudal limb of that septomarginal trabeculation. And that now means that the interventricular communication is free to open both into the aorta and into the pulmonary trunk. And that is why we have double outlet from both ventricles. Here you see the situation with a fibrous outlet septum. But in this lovely picture made available to us by Vera Aiello from Sao Paulo, we see another example of double outlet both ventricles. Again, you see the interventricular communication opening between the limbs of the septomarginal trabeculation. And this time, because that muscular outlet septum has attachment neither to the cranial nor the caudal limbs, septomarginal trabeculation, the defect opens both pulmonary route and into the aortic route. This time with a muscular outlet septum. And so we're going to have a spectrum here when both arterial routes are overriding, and that spectrum now is going to be from double outlet right to double outlet left ventricle. And the intermediate variant this time is going to be the arrangement I've shown you in those previous two pictures, double outlet, both ventricles. So let's now ask Diane to finish off and look at the specimens by showing us her example of double outlet, both ventricles.
We're looking at this heart from the anterior aspect and in attitudinally appropriate fashion, so that the free wall of the right ventricle has been previously removed. And in a moment, I'll show you that the heart has been sectioned in parallel with the interventricular septum. Looking at the arterial trunks as they leave the ventricular mass, the aorta is anterior and rightward of its usual position, so that it is now side by side and to the right of the pulmonary trunk. The pulmonary trunk is also of a much smaller caliber than is the aorta. If we look at the sectioned components of the specimen, you can see that this is the interventricular septum. And remember, the right ventricle will be anterior to that. Here we see the anterior-most portion of the morphologically right atrial appendage and a little bit of the tricuspid valve. So we're looking at this specimen from the spine towards the sternum. There is an interventricular communication. You can see the crest of the muscular interventricular septum. Looking at the arterial valves, they are in fibrous continuity with one another, and this is a doubly committed and juxta-arterial defect. If I push the pulmonary trunk backwards a bit, you can now see that small fibrous outlet septum just at the tip of my probe. When the outlet septum is fibrous and not attached to the cephalic or the caudal limb of the septomarginal trabeculation, the arterial roots can be arranged so that they arise from either ventricle and can be described as a double outlet, both ventricles. So if you remember that triangle of space that we've been talking about, the arterial trunks are free to float above or within that triangle of space and above the interventricular septum.
So that's it. To understand overriding arterial valves, we need to remember our four spectrums. Because overriding can involve the aortic valve, with or without subpulmonary stenosis, the pulmonary valve, or it can involve both valves. In fact, there is then a fifth spectrum, that involving the common truncal valve, but we've not discussed that with you today. What we have shown is that all of these valves override in the setting of outlet defects, and those defects can either be perimembranous or muscular, and it is that feature that will determine the vulnerability of the atrioventricular conduction axis. But most importantly, what we have shown you, I hope, is that the extent of override will determine the ventricular arterial connection. And depending on the extent of that ventricular arterial connection, we have established a pragmatic means of determining whether the surgeon is going to close the defect or channel it to the overriding arterial route so as to restore septal integrity. That channel closed will always be the communication from the right ventricle, because that is the way we put the overriding arterial route back into the left ventricle. And for me, I prefer to call that plane the ventricular septal defect, since that is the plane that is closed to restore septal integrity. But you will make your own decisions, but hopefully today we've given you the anatomic information that will permit you to make up your mind. So thank you for your attention. We're now going to open our session to further discussion. Thank you.
Well, those of you who have been watching, hopefully you've enjoyed that. As I promised from the outset of the session, the videos that Diane prepared for us today, I think have been truly spectacular. But Diane, do you have any more words you would like to offer to our participants before we ask Norman and Adrian for their comments?
Yeah, I think one of the most important things that hits me from this presentation is that in the past I have mischaracterized or misdiagnosed the doubly committed ventricular septal defect, where you can have a double outlet both ventricles. And I think the important point for people to remember is that outlet septum, whether it's fibrous or muscular, is almost in a perpendicular position relative to the crest of the ventricular septum. And I think that's the important point for not mixing these things up with plain old juxta-arterial VSDs in cases that have a fibrous outlet septum with the tetralogy variant, and also within the whole spectrum of what we talked about today. But I think that's an important point, to look at the perpendicular nature of the outlet septum relative to the muscular ventricular septum.
I think your presentation showed us that very beautifully. I know, Adrian, you had also been concerned about this because you'd made the point that there's been some confusion as to what we call the doubly committed ventricular septal defect. And obviously it's when the outlet septum is not attached to either the caudal or the cranial limb that we have that doubly committed defect. And we've got into trouble with that because previously we've also said that the juxta-arterial defect is doubly committed, but we now know that is not necessarily the case. So the juxta-arterial defect can in fact be subaortic rather than doubly committed. But do you want to make further points about that, Adrian?
It was just to clarify that in the context of double outlet both ventricles, because there is a degree of commitment of the defect to both arterial outlets. So people will think that, yes, there is double outlet, double commitment of the defect, or is double commitment of the arterial outlets to the ventricles, because we are talking about commitment either for the arterial outlets or of the defect itself. So that's where I see that there is confusion, because we can use commitment in two different ways here.
How would you resolve the confusion?
It's either accepting the difference, because we don't have two words. We don't have to either reserve the term juxta-arterial for those whether there is fibrous continuity between the arterial valves, even if there is a fibrous remnant of the outlet septum, and we call them juxta-arterial. And then when it comes to commitment, to doubly committed, it can be the defect, that is the VSD, doubly committed to the arterial walls. But in the context of double outlet both ventricles, we have to understand the commitment regards the orifices of the outlets towards the ventricles, because they are, I can show a nice specimen like Diane showed, whether both orifices are committed at the same time to both ventricles.
Indeed. I think that's to me, that would be my preference now. As you say, we use commitment to say the way the ventricles are looking into the arterial roots. We use juxta-arterial to define the specific arrangement in which there is fibrous continuity between the leaflets of the arterial valves, accepting that there may be a fibrous outlet septum as part of that continuity.
And then there is a third aspect of commitment when we talk about non-committed versus committed. So that word commitment, it's really plagued with a bit of confusion. That's why we have to really explain it well, because that's a surgical term, the commitment of the ventricle.
Indeed it is. And I mean, as you know yourself, the surgical commitment depends very much on the eye of the beholder when you go in the operating room, does it not?
Absolutely.
Norman.
Yeah, thank you very much.
Is that all you have to say? Are you still with us, Norman? You're muted now. We can't see you, but are you hearing us? We seem to have lost Norman, which is an unusual situation.
Until Norman is back. Is he back?
No, he doesn't seem to be. Norman, are you back?
I have a problem now, Bob.
Oh, we can hear you now.
Okay, great. What my problem is just two problems that I'd like to bring up. The first is that looking as an echocardiographer at this, it becomes very difficult to see the limbs of the septomarginal trabeculation and its relationship to the outlet septum. And so it doesn't seem to be a problem when the defect is a subpulmonary type of defect. But with the subaortic type of defect, there is a tendency to miscalculate whether you're dealing with double outlet or a tetralogy type of lesion. And I think that usually if you see the deviated outlet septum, which is something that I think is easily recognizable by ultrasound, you can make the diagnosis of tetralogy. But if you don't see that, double outlet becomes a difficult ultrasonic distinction of those two things. So that's the first question I wanted to ask you, Bob, is what, as an echocardiographer, would you do to diagnose the differential between a double outlet and a tetralogy?
Well, I'm not an echocardiographer, no. You're going to have to answer that question.
Well, I think that there's still going to be a dilemma, and I think that it can be sorted out. But I'll just point out to you that the billing for diagnosing a tetralogy versus double outlet is different. So there's a tendency always to diagnose the more complicated defect. And so I think that double outlet with a subaortic ventricular septal defect is often overdiagnosed. In the end, it doesn't really make any difference because the surgeon still has to close the ventricular septal defect to the left ventricle.
Absolutely. But the problem is that at the moment, we're still calling it the ventricular septal defect when it's the aorto-left ventricular communication.
The green one.
That's what we have to get away from, and we have to recognize that that space is the outflow tract from the left ventricle. At the moment, as you say, in double outlet right ventricle, we don't have a name for the area over which the surgeon is going to tunnel the route back into the left ventricle.
Yeah.
And Norman, I think the solution was given by Francois Lacourgaillet, who said that if the patient survives, it's a tetralogy. If it doesn't, it's a double outlet.
Okay, I understand that. The one other point, Bob, that was intriguing to me was with Vera Aiello's case of double outlet both ventricles, is as you look at that as a surgeon, and maybe Adrian, you can chime in on this for us, is how do you repair that particular case? Because as I looked at it, it seemed very difficult. I don't know, Bob, whether you can put that specimen back up there.
No, it's difficult to do that, Norm. I don't have my my screen open to there, but I mean, it was really my colleagues in India who worked out what to do. Initially, they used 2 patches, and they. Oh, Adrian, have you got? Can you answer it for?
I have one specimen, if I can show it quickly. So in attitude, I'm not as good as Diane, so I'll go quickly through it. This is the anterior surface. You can see here a large pulmonary trunk. The aorta is here. I didn't have time to dry them, so they are slippery. The aorta is here, if you can see, and the outflow tract between. I'm lifting the portion that is.
Oh, that's beautiful, Adrian.
Yes, and look at this. I mean, look.
Oh.
So this is the pulmonary trunk again. It's here. Yeah, you can see the leaflets. The orifice is here, where my white finger is. This is the aorta, yeah, where the forceps is. So if I lift the structure in between, this is the fibrous outlet septum. You see it in between the two orifices. And now this outlet septum is suspended because this is where the limbs of the septomarginal trabeculation is. And this is the defect. So you can see how the fibrous outlet septum is perpendicular. This is the fibrous outlet septum perpendicular to the crest of the interventricular septum. So from both ventricles, from the left, I can go into the pulmonary trunk. From the left ventricle, I can go in the aorta. From the right ventricle, I can go in the pulmonary trunk. From the right ventricle, I can go into the aorta here. Because of the perpendicular position of this fibrous septum across or against the crest of the ventricular septum. So it's a very, for me, it's quite clear, a double outlet, both ventricles. And you can see how the spectrum is, because it's enough if I pull this towards the aorta, it will be more from one side, or if I pull it on the other side, it can be more of the other 2 arterial outlets. So it's a very nice specimen. Wherever I show it, people understand what it means, a double outlet, both ventricles, because of the position, the relative position of the fibrous septum here. You can see it all the way here against the supraventricular crest.
And if you wanted to repair that, Adrian, you'd have to place 1 patch to complete the division between the outflow tracts, and then you'd have to place another patch to put the aortic component of that back into the left ventricle. And this was the point that Krishna Iyer made when he produced 6 examples that he and I worked on together. And he worked out in the operating room, it was much easier for the surgeon to correct this using 2 patches than to try to put 1 spiral patch that you'd have to put in so as to put both of the arterial trunks into their appropriate ventricles.
Because you see, the aorta should come through this VSD into the left ventricle, yeah? My white glove. So the patch will have to come here and compromise the other orifice. My blue finger is in the pulmonary trunk. So sometimes you can either negotiate a patch like this that will allow the aorta into the left ventricle, compromising the pulmonary trunk. So sometimes you have to put a jump RV2PA conduit, or you open the right ventricle and you do it like in a tetralogy where you put a patch here on the right ventricular surface, because this orifice obviously will become compromised by the aorta. We always try to prioritize the aorta, obviously, into the left ventricle, or a spiral 2 patches, but that's really complicated, and you need 3D printing for that and 3D modeling, as I was showing in the But this is what our priority will be, to actually place the aorta, tunnel the aorta into the left ventricle across the VSD.
Indeed. The interventricular communication, we're still using VSD very, very loosely.
Yes, yeah, and that was one of my questions, because you are moving away. You don't prefer to call interventricular communication with two openings to the left and right ventricle.
Well, I think if we get back to the aorta right ventricular, the pulmonary right ventricular, we have to be precise with each of the various spaces. That's the only way for, if we want to have precision.
I see.
Well, thank you very much, Adrian, for showing me that. I still don't know how you're going to put the patch down.
I think that's something you have to work in the operating room, Norman. I think the individual surgeon will intuitively know how to place the patch. But I think that, as Krishna Iyer said, it's often easier if it was easier for him to use two patches than to try to create a spiral patch.
Where does he put the patches? Because the surgeon isn't going to see the specimen the way we show it. He's going to be coming through the tricuspid valve or through a right ventriculotomy. And his vision is going to be so much compromised compared to what we can see with the autopsy.
The opening of the right ventricular outflow tract here will give access to the fibrous septum, either muscular or fibrous septum. So that's the first aspect that allows you to anchor your aortic patch, because that's what you want to create this aspect. So you'll move the outflow, the outlet septum more towards the pulmonary trunk in order to allow the aorta to go into the left ventricle. And then the problem is that you create subpulmonary obstruction. And how you deal with that, you either open anteriorly, like in a tetralogy, to put a transalveolar patch, or you do an RV2P conduit.
Okay, all right. Well, that would be easy. But I can see still it's a very difficult surgical repair.
It is. And sometimes you are lucky because the arterial trunks are dilated. So you can approach them from above as well, the defect.
Would you put on an outflow patch, because you compromise the RV outflow tract, would you put on an outflow patch as well? Is that what Dr. Iyer is talking about, the second patch that he puts on?
Not necessarily, not necessarily.
No, he does a spiraling of these two patches, which I haven't seen it personally. No, that's a different thing. It's not the second patch being the transalveolar patch. No, it's an intraventricular patch, the second patch.
Okay. Well, I'm happy I'm not a surgeon.
Yeah.
Well, it sounds like you have equal problems now as an echocardiographer in sorting things out.
Well, I think that 99% of the stuff is easily sort outable. And
it's interesting what you say, that you're having problems in working the relationship of these various structures, because those are the questions we really need to be answered if we are to resolve these problems.
I see that, and that's what I was mentioning is the upper border of the event of the septomodular trabeculation is not easy to see. The lower borders and the lower parts are easy to identify. So that communication of the septomodular trabeculation with the outlet septum, be it the anterior or the posterior, is difficult to recognize on an ultrasound study.
So this maybe points to the fact that 3D modeling is increasingly needed, and we need the CT image, the CT scan, so we can do 3D modeling.
Or an MRI, yes.
Or
I think
MRI.
that's true. That's true. I mean, we have to accept that all techniques have got limitations, and we have to do what we can with the best that we have with the technology that's available to us.
Yeah. This was another specimen of Taussig-Bing that I wanted to show, because it's really, really nice. We can see the aorta here, the pulmonary trunk here. This has a small arch as well. So this would be the arterial duct. It's a small arch here. But look where the opening into the left ventricle is, because you'll see that this is the left ventricle here, left anterior descending artery. This is the opening in the left ventricle. You can see the mitral valve down there. This is the mitral valve that I'm picking up. But the opening is close to the pulmonary trunk. You can notice the pulmonary trunk. The aorta is on the other side, further away. This is the aorta with the small arch that we can see here. So it's a very nice example of a Taussig-Bing I want.
And Adrian, if you look at that, you can show them where the surgeon is going to place the patch to tunnel the pulmonary route into the
Of course.
there we go.
Because
and he's going to tunnel it through the interventricular communication. But at the moment, we don't have a name to describe the area over which the surgeon will place the patch.
Yes.
And of course, Bob, we're thinking that we're going to have to do an arterial switch at the same time. Yeah?
Yes. You see here, the patch comes here. This is tricuspid valve.
That's easy.
So we'll have to use here the edges of the VSD. Go here. This will be the edges of the patch, because this is now the pulmonary trunk, but it will become the aorta after the switch.
Right.
So this where the patch will be. Yeah.
We have Natalia who wants to talk. Natalia, if you unmute, if I'm working things properly, you should now be able to speak. Unmute yourself and speak. Natalia, you're still muted at the moment. Can you unmute? She said she wanted to speak, but she's gone again.
The value of the 3D print, just to show this, because you can see the aorta here, the pulmonary trunk. Then only by being able to take apart the ventricles, you'll see how both trunks are coming from the right ventricle, the green one, not from the yellow one, which is the left one. So it's really useful, because such reconstructions will help surgeons. But remember, in theater, in the OR, our hearts are still in a flaccid manner, like the specimens that Diane beautifully showed. So it is important to realize that the specimens still hold a lot of value, because this is how the surgeons will see in theater, in the OR. We don't have the flow modeling that Norman can achieve with the echo. That's what would be useful for us. But we still deal with them like this in theater.
Okay.
Well, it was a sobering experience listening to you today, Diane and Bob, and thank you very much for all of those beautiful specimens.
Well, indeed. So Natalia doesn't want to be promoted. So.
Well, one last question, Prof. It's about the coronary arteries in overriding arterial valve orifices. Do you reckon then whenever there is an overriding, there is an increased risk of having unusual coronary patterns?
I don't think that would be the case if the aortic route is overriding. I think that when the pulmonary route is overriding, so in the Taussig-Bing spectrum, certainly then there is a greater chance of having an unusual pattern, but not when it's the aortic route that's overriding.
Okay, thank you.
Okay, well, Norman, thank you for being with us. Diane,
thank you so much.
Spectacular videos, and that's our final session for spring. We have to think as to what we're going to do in future, but likely we're going to have a summer break because we're all very busy. So maybe we'll all get together again in the autumn. So thank you all for being with us.
Thank you. Bye.
Okay, bye.